Stanford Conversations in Menopause and Healthy Aging, the podcast, a trusted science-backed resource in menopause and healthy aging. When it comes to your medical and health education, tune in and submit your questions to world-class leaders in medicine and research. Stay informed, stay empowered, because your health matters.
Hello and welcome back to Stanford Conversations in Menopause and Healthy Aging, the podcast about living well through perimenopause, menopause, and beyond. I'm your host, Dr. Karen Adams, board-certified OBGYN and lifestyle medicine physician, and director of the Stanford program in Menopause and Healthy Aging. Today, we are discussing one of my favorite topics, sleep. I absolutely treasure my sleep, and I get very cranky if I've had a couple nights in a row of bad sleep. And sleep disturbance is a big deal for women in midlife and beyond. I see it so much in my patients, and they tell me that not sleeping is worse than their hot flushes. And that makes sense, right? Because when you're not sleeping, it seems like everything else is just off. My guest today, Dr. Natalie Solomon, is a clinical assistant professor in the Department of Psychiatry at Stanford University School of Medicine. She's a licensed psychologist and board certified in behavioral sleep medicine. Dr. Solomon and I wrote a paper on sleep disturbance and menopause that was published last fall in a medical journal. And it was our hope that the paper would help providers be able to guide their menopausal patients to a better night's sleep. And in this two-part series on sleep, Dr. Solomon and I will chat about all the information in that paper and more so that you can stop all that tossing and turning at night, get to sleep, and stay asleep. Welcome, Dr. Solomon. I am so happy to have you with me today.
Thanks so much for having me, Dr. Adams. I'm really happy to be here.
Okay, well, let's dive in. This first part is all about risk factors for sleep issues and what sleep disorders actually look like. So first things first, I see so much sleep disturbance in my practice. And do you see it frequently in your perimenopausal and menopausal patients too?
Yes, absolutely. The sleep disturbances really increase in prevalence during the menopause transition, and the most common complaint is middle of the night awakenings.
And you know, when we look at the menopausal science around this, about 50 to 60% of our menopausal patients report some kind of sleep disturbance. So why do you think that is?
Yeah, I'll start by saying, it's really multifactorial. So there are many contributing factors to the sleep disruption that we see across the menopause transition. Firstly is hormones. So hormones themselves disrupt sleep through the transition. Secondly, vasomotor symptoms, so night sweats and nocturnal hot flashes, also disrupt sleep across the menopause transition. Thirdly, there's kind of a co-occurring impact of aging in sleep. So there are some known changes that occur in sleep as we age that's often happening at the same time. And then on top of that, there's a strong relationship between mood symptoms and sleep disruption. And for many, mood symptoms can worsen or increase during the menopause transition. We'll talk more about this piece later, but there's also a change in muscle composition that occurs during menopause that can impact one's breathing during sleep. And then, there's beyond that, we have to think about comorbid conditions and additional medications that might have entered the picture. And then kind of lastly, I always think we don't sleep in a vacuum. We really sleep in the context of our lives. So lastly, considering things like life phase, midlife women may be experiencing changing roles at work or at home, new stressors, and this can also impact sleep.
Oh, sounds like a perfect storm
Exactly.
of all kinds of different things. Are there specific types of sleep disorders that you see primarily in this time frame of a woman's life, or are they all of them?
Now, it's a great question because it really helps to define what is the specific sleep complaint. So,
Mhm.
firstly, we'll talk about insomnia disorder. So, insomnia disorder is when someone is having frequent difficulty falling asleep, staying asleep, or both. So, this is, someone's having a really hard time basically initiating or maintaining sleep at least 3 nights a week. So, about half of the nights. Estimates show that something like a quarter of perimenopausal women meet criteria for insomnia disorder, so this frequent disruption to their sleep. So that's one piece. Another piece is that there is an increase in disorders of sleep disordered breathing. So, may have heard of, many people may have heard of sleep apnea, which is kind of the partial or full frequent obstruction of the upper airway in sleep. In other words, it's that the airflow is either blunted or the amplitude decreases temporarily over and over again. And so sleep disordered breathing also increases through the menopause transition, in part because of this muscle change that occurs. And then, we have another category of sleep disorders, which is restless leg syndrome. So, restless leg syndrome is like an uncomfortable feeling in your extremities in the evening that makes you want to move them. And the feeling remits with movement. And so the prevalence of restless leg syndrome in general increases with age and is more common in women than men. So, kind of as you can see here, we have sleep disorders in different domains. We have insomnia, we have sleep disordered breathing, and we have restless leg syndrome.
Okay. And you know what my patients are telling me is that they are waking up in a pool of sweat. And so that makes me wonder, are they sweating and that's making them up, or are they waking up and then they're sweating? Do we know anything about that?
So, I think this is really interesting. Both can occur. So, people often experience that they think it's the hot flash that awakened them.
Mm-hmm.
But in many objective studies, so where they're really looking at skin heat as well as objectively measuring sleep, both can happen. The hot flash can occur slightly before the awakening. The awakening can also start to occur slightly before the hot flash, or the two can occur in such strong overlap. And so, this really suggests that these events may be driven by a common mechanism in the central nervous system. And this could be in response to fluctuating estrogen levels.
Mm-hmm.
That being said, after the hot flash has occurred, sweating or being uncomfortable can still contribute to or extend the interval of awakening.
Mm-hmm. Right, because a certain amount of awakening at night is normal, right?
Correct.
Like what is normal?
Yeah, so in total, let's say you have a few brief awakenings, and if in total they add up to about 20 minutes awake, we would say this is somewhat normal, especially as a person ages. But if you're having 3 awakenings and they're each lasting, somewhere between 20 and 40 minutes, and so it's adding up to an hour plus awake in the night, this would be considered an insomnia symptom.
Mm-hmm. Right. You know, what I always tell my patients is we think it's pretty normal to wake up twice a night to pee. But then the question is you get up, you pee, you get back in bed, then what happens?
That's really well said. Yeah.
Would you agree with that?
Yes, absolutely. And I would say similar for hot flashes. If you experience nocturnal hot flashes, if you have one a night and you're able to get back to sleep easily, then it's not necessarily a problem. But if you wake up in the night and you have a hot flash and it's very difficult to return to sleep, then that's probably something that you want to treat.
Mm-hmm. Right. And I'm already so curious about how we would advise people about the treatments of that, but we will get to that. So we did talk about how the hormonal fluctuations can really impact this or exacerbate our sleep difficulties. What about if people are going through early menopause? So sometimes people have had surgery or some kind of medical treatment that have thrown them into menopause. Are those sleep disturbances going to manifest any differently in those people?
Yeah, thanks for asking that. So, relative to natural menopause, women who experience surgical menopause are over twice as likely to experience difficulty with sleep initiation and maintenance. So, it places one at even greater risk for struggling with their sleep.
Mm.
Part of this is explained by more severe hot flashes. So, those with surgical menopause sometimes experience more severe hot flashes. And this finding is maintained no matter how many years have passed since the surgery.
What?
Yeah, so it's not direct aftermath of the surgery. It's actually a true change in one's vulnerability to sleep disruption.
Oh my. And so that means if someone goes through a medical menopause at, say, age 35, and the average age of menopause naturally is 51, 52, that person can expect to have more sleep difficulties kind of through that entire transition?
Yeah, this data is coming from the SWAN cohort,
Mm.
and kind of it demonstrates that even independent of years since surgery, the vulnerability exists. That being said, it's just a vulnerability. And I say it that way because there still are treatments and people are responsive to treatment. So I guess we'll get to that in part two, but it
Mhm.
just means one's at increased risk.
Mhm. And what other risk factors are significant for that put people more at risk for poor sleep?
Yeah, so we've talked about surgical menopause.
Mhm.
Another piece is there's a strong relationship, unsurprisingly, between severity and frequency of nocturnal hot flashes and sleep disruption. One having a history of depression is also a risk factor for struggling with their sleep in menopause. And if one has any history of struggling with mood symptoms during any other reproductive transition. So, for example, if this is someone who struggled in the premenstrual week with their mood, or if this is someone who experienced, for example, postpartum depression. And then lastly, there's this strong relationship between chronic high stress and sleep disruption. So, for
Mm.
people who have experienced a lot of stress, they're more vulnerable for sleep disruption during the menopause transition.
Mhm. And often these symptoms happen even before periods start changing or hot flushes, that sort of thing. Is that correct?
Yes, absolutely. I would say most of them. Yeah.
Most of them. So so you would we think about this as kind of a red flag for caution, caution, here comes perimenopause if we start seeing these kind of sleep disruptions associated maybe with mood as well?
Yeah, potentially. So I would think you could think of it potentially as is there a hormonal contributor here? So it could be a nice thing to think about, to track, to talk to your provider about. So if you're kind of seeing a worsening in your sleep, it's quite possible that it could be one of your first symptoms.
Mm.
It's also possible that, sleep disruption occurs outside of the context of menopause. So it's really about kind of mapping it onto your timeline and your cycle.
Mhm. That makes sense. And it's so interesting, the intersection of mood and sleep, right? Can you talk a little bit more about that? About is it a chicken or the egg kind of thing? Or, how
Mm.
do you think about those two?
Yeah, you very much read my mind. So it's a fully bi-directional relationship,
Mm.
meaning, I guess we all know this in ourselves to an extent, right? When one is struggling with their sleep, they're much more vulnerable for mood symptoms and mood disorders. And the opposite is true as well. When one is navigating a mood disorder, they're much more vulnerable to sleep disruption. And so it can become quite cyclical in nature. And we know during the menopause transition that and in part because of hormones, one is more vulnerable to some mood symptoms, which further contributes to this vulnerability with sleep.
Mhm.
That being said, if someone is struggling with their sleep, even in the context of a mood episode, so for example, they're navigating depression and struggling with their sleep, um, it's the sleep difficulty still warrants its own diagnosis and treatment. So what I mean by that is, I wouldn't say, okay, well, then we just need to treat the depression, because there's actually some research demonstrating that the insomnia can be quite a residual symptom.
Mm.
There's also research demonstrating that the insomnia, even treated in the context of menopause, hot flashes, and depression, is treatable. So there's kind of a hopeful piece in there too, which is that the sleep disruption would respond to treatment even with these other comorbidities.
Oh, thank goodness.
Yeah.
I mean, this is starting to sound so overwhelming, and we talked about this when we were writing the paper, how it's almost like a Venn diagram of overlapping circles. There's the mood and the sleep and even the brain fog and cognition that is all kind of manifesting together. And we'll have a whole separate session about brain fog and cognition and all of that. But certainly, I don't know, maybe it's because I treasure my sleep so much that I feel like everything flows from sleeping well, and that if I'm not sleeping well, everything else is off. And I would imagine I'm not the only one who experiences it that way.
Very much. I mean, it's deeply connected to so many aspects of our health and well-being.
Mm-hmm. And so, in terms of our physical health, what's the impact if people are not sleeping well? Does that put us more at risk for other kinds of health issues?
Yeah, it's a great question. So, I'm always careful when I think about this because I think really different messaging is helpful for different people. So,
Mm-hmm.
if you are someone who maybe minimizes your sleep disruption, maybe even providers have minimized it for you and said, oh, it's just a part of menopause, or you're someone who doesn't prioritize your sleep, it can be really helpful to know that how sleep is connected to many other areas of our health, including, let's say, immune function, memory, mood, and aspects of our quality of life. And so for these people, it may really help to prioritize sleep and seek treatment if you're struggling with your sleep.
Mm-hmm.
On the flip side, if you are someone who is really trying to sleep and is unable to sleep, so let's say, you get into bed and you fall asleep, but then you wake up in the night and you can't get back to sleep, ongoing messaging about the importance of sleep can be very stressful. And so for these people, I would also want them to know that there's some nice science behind how, even on a night of really suboptimal sleep, our daily functioning is largely intact, especially as we age. So, actually, as we age, we become more resilient to the impact of sleep loss. And for these people, kind of this ongoing narrative about the importance of sleep for our health can actually worsen their insomnia. And so I would want them to know that some of the findings on short sleep and physical health have not yet been established in the insomnia population. So, meaning when you see headlines that say things like, if you sleep less than 6 hours, you are at risk for A, B, and C. Many of those headlines are actually referring to shorter sleepers. So people with like an insufficient sleep opportunity who are working all day and caring for family and don't have much time to sleep. And they don't necessarily translate to someone who's trying to sleep and unable to.
Oh my goodness, that's so interesting. So, right, that sort of self-talk about, oh my gosh, I've been awake for 20 minutes, tomorrow's going to be terrible, and I've got this big thing to do. That is just going to be so not helpful.
Yeah, and maybe not even true. Sometimes we can surprise ourselves. Not that sleep doesn't matter, it matters very much. And our presentation tomorrow is probably largely intact.
Mhm. Oh, that is so reassuring to hear. So reassuring. And then, so say I've referred someone to you because I think their sleep disturbance is bothersome enough that I want them to have a conversation with you. How are you going to begin that evaluation? How are you going to sort out what's going on?
Yeah, I love this question because I think in general, we all speak quite broadly about sleep. We'll say things like, oh, I'm not sleeping well. It really helps to better define the specific ways in which a person is struggling with their sleep. So, specifically, if I'm going to ask someone about insomnia symptoms, I'll ask something like, are you having frequent difficulty falling or staying asleep? And I'm holding in mind that piece we talked about before of, brief awakening in the night is normal. But if a person's awake for in total more than 20 minutes, and this is happening on about half of the nights per week, then they're struggling with insomnia symptoms.
Mm.
A nice assessment tool is something called the ISI, the Insomnia Severity Index. Separately, and for these people, a sleep study is not indicated. It doesn't really make sense to go and sleep in the lab for them to say, you're right, you did struggle with your sleep this night. It's just one night of data. For someone else who says, I feel really fatigued during the day, Maybe I'm waking up briefly a lot in the night. My partner says I'm snoring, and so I'm suspecting maybe sleep disordered breathing or sleep apnea. I might ask them things like, do you ever wake up with a dry mouth? Do you wake up in the morning and the sheets are really tangled? Like, does it look like you're moving a lot in your sleep? Are you having kind of ongoing fatigue during the day? And for that person, if I suspect sleep apnea, I might do a screener like a stop Bing or a Berlin. These are brief screeners, but in general, I would want to refer them for a sleep study
Mm.
because for sleep apnea, an overnight sleep study is the best way, is the only way to be diagnosed and have access to treatment.
And a sleep study actually involves someone going to a sleep laboratory and sleeping there overnight. Is that what that is?
So there's two options. There's in-lab sleep studies in which that's correct. You go to a facility, you sleep there overnight, and kind of your sleep and your breathing is monitored. There's also at-home sleep studies. So for some people, we mail them a device that they sleep with at home, and they mail back, and we're able to look at the data and see how their breathing was
Mm.
overnight.
I see. And circling back to the insomnia severity index, I think you mentioned. What are the sorts of things that's assessing? What kind of questions are people answering about that?
Yeah, it's asking things about one's on current sleep habits. So
Mm.
things like, when you get into bed, around how long is it taking to fall asleep? How many times are you waking up in the night? When you do wake up in the night, how long are these awakenings lasting? And it's also asking about daytime symptoms. Because of your sleep, are you experiencing daytime distress or impairment,
Mm.
essentially?
I see. Okay. So that makes sense. So it's kind of a symptom report. I think people are always afraid they're going to have to do diaries or something and
Mm.
keep track. Do you ever use those?
So, in treatment for insomnia, I will use sleep diaries. So, when I'm working with someone, week after week, and we're really seeing how their sleep changes through our time together, I will sometimes ask them to track their sleep on a sleep diary so we
Mm.
can really look at the data together and come up with individualized recommendations.
I see, but not so much when you're assessing it to begin
Right.
with. You
Probably
know,
not as a screener. Yeah.
my burning question that I'm going to finish up this part one with is talk to us about wearables. Things like rings or our Apple watches. Are those helpful in diagnosing sleep issues, or do they just muddy the water?
It's a great question because it's very related to what we've talked about so far.
Mhm.
So, I think wearables can be really helpful if someone is identifying some area of behavior change. So, for example, if you are trying to go to bed earlier, it's kind of nice to look at the data and see when have you been successful, when have you not been successful, what's gotten in the way. Or for example, if someone's trying to get up at the same time every day, they can kind of look at the data and see what they're doing.
Mm.
In terms of sleep disorders, there are some wearables that will suspect sleep apnea. So there are some wearables that will say, we picked up on some kind of breathing patterns and we want you to go and get a sleep study. That being said, you still need to complete the sleep study to know for sure if you meet criteria.
Mhm.
Wearables are not very helpful for insomnia. Firstly, because they're actually less accurate. So, for people who wake up a lot in the night or have difficulty initiating sleep, the wearable's accuracy really decreases. Sometimes the wearable thinks you're asleep, but you're awake, or vice
Mm.
versa. The second is kind of what we talked about before, which is that the wearable can actually increase anxiety, thereby worsening sleep. And there's some interesting research on this where they gave kind of sham wearable feedback. So research participants received feedback about their sleep that wasn't even accurate, and it did inform how they felt through the day. So if they were told they didn't sleep well, they actually felt worse, had increased fatigue. And so I wouldn't recommend a wearable for
Mm.
someone navigating insomnia symptoms, but I could see areas where it could be quite helpful.
And that's first of all, I would be so angry if I were told that I'd slept badly and it messed up my next day. But
Yeah.
that's really good information, though. That's really important data to know, that you can be quite suggestible in that realm. What about quality of sleep? Sometimes people will say, well, my Aura ring or my whatever, my wearable's telling me I'm sleeping, but it's not great quality sleep. Is that a real thing?
Yeah, so it is true that there's a difference between quality and quantity, right? So the quantity is number of hours slept, and the quality can refer to different components. So I normally like to ask people, tell me more what you mean by that. So,
Mm,
for example, sleep apnea could compromise the quality of a person's sleep. Maybe they're getting 7 hours of sleep or something, but the sleep disordered breathing is really kind of puncturing the sleep, and
mm,
thereby they don't feel very good during the day. Quality can also refer to how many awakenings occur. So, for example, someone with insomnia might ultimately get a decent amount of sleep. Let's say they go to bed at, I'm just making something up, 9 p.m., and they wake up at 9 a.m., and in there they're awake for 3 hours. So they're actually getting 9 hours of sleep. But with that 3 hour awakening, the quality is quite poor.
mhm.
So, first, I would say there is a difference between quantity and quality.
So I've heard you mention the term sleep architecture. Can you explain to us what that exactly is?
Yeah, thanks for asking that. So, sleep architecture details the amount of time a person spends in the different sleep stages. So, architecture is kind of a nice word for it because when you look at a hypnogram, which is a graph of your sleep architecture, it does kind of look like a cityscape, but essentially it demonstrates the amount of time a person's spending in REM sleep and the different stages of non REM sleep. And it's normal to cycle between stages throughout the night.
I see. And then by the end of the study, you have mapped that and created your own kind of city skyline. And that's
Exactly.
sleep architecture. Got it. That's very well named.
I know, I enjoy that one.
Right. Mm,
That being said, the wearables don't always do the best job of sleep architecture. So we
mm,
actually can't use many of the consumer wearables in research because they struggle a bit with sleep architecture. So if someone's wearable is saying to them, you didn't get an adequate amount of deep sleep, I'm not exactly sure if I would trust the accuracy of that data. But if
mm,
it overlapped with the person's experience, if they said, I did feel like I was in a shallow sleep with many awakenings, then I would want to attend to that and maybe further investigate with them
mm.
what would be a reasonable next step.
That makes so much sense. I always learn so much when we chat, Dr. Solomon. I am so impressed by how many women really struggle with this, especially in midlife and beyond, and really how impactful that can be for them. So thank you so much for being with us today.
I've loved being here. Thanks for having me, Dr. Adams.
And now we are not going to just leave you with, wow, that's a problem. We are going to talk in part 2 about what we can do. And you and I've been dancing around this a little bit, and I'm really interested to hear about the treatments for it. So please do join us for the second part of our series on midlife sleep issues, where Dr. Solomon and I discuss treatments.
If you've enjoyed this episode of Stanford Conversations in Menopause and Healthy Aging, please take a moment to follow or subscribe to our podcast on your favorite platform and consider leaving us a rating or review. It's a simple, zero-cost way to support our work and help others discover the show. You can also stay connected with us on Instagram, YouTube, and other social media at Stanford Menopause. For additional resources, event notifications, and other updates, be sure to visit our website, menopause.stanford.edu, where you can also sign up for our program newsletter. Thank you for joining us, and most importantly, thank you for your interest in advancing the conversation around menopause and healthy aging.